This conference will now be recorded.
So good morning all of you. Today's topic given to me is the nutritional anemias. In the examinations, if you are asked about nutritional examination, in the question as on the nutritional anemia, this is how you have to appear, because already you know how to approach to anemia, already you have gone through. So I will cover only the nutritional aspect of anemia today. Everybody is familiar what is anemia. The definition of anemia is a reduction of hemoglobin concentration or red cell volume below the range of values occurring at healthy persons for the age specific, for whatever given age. And also oxygen carrying capacity of the blood is diminished. That is also an anemia. When you say it is a nutritional anemia, the anemia that results from inadequate intake or assimilation of materials essential for production of RBC and hemoglobin. So the causes actually all those hemolytic and blood loss and all these things you can just eliminate. So here the cause is definitely due to inadequate intake or assimilation, because either intake is good but it's not getting into the body, either malabsorption or some other reason. So assimilation of both together, absorption and getting integrated into the hemoglobin is called as a assimilation. So this is anemia. Nutritional anemia's definition is this one. Then well, what is anemia? The definition actually age specific, as we are telling actually, but this is a simplified table for you, because anything in pediatric is not a fixed value, as you remember. So everything is age specific. What is for the newborn is different for the older people, or the adolescent entirely different, like that. So roughly this is the thresholds. Below that level, it is called anemia. So we are given two parameters. One is the hemoglobin concentration, other is the hematocrit also. So in children between 0.5 means 6 months to 55 years, 11 grams is cut off, or hematocrit of 33%. Whereas 5 to 14 years children, it is 12 grams. Even anything below 12 itself is an anemia. Or in terms of hematocrit, it is 36%. Women, non-pregnant and above 15 years, again the same, 12 grams and 36%. Whereas for pregnant women, even 11 grams is again just like a small children. Cutoff value is 11. Because naturally the anemic pregnancy causes a little anemia because of hemodilution. So your cutoff is a little less. So if it goes below 11 only, you call it an anemic in pregnant woman. That is 33% hematocrit. But in men above 15 years, anything below 13 is itself is anemia. So men are supposed to have better hemoglobin concentration. So there is hematocrit in terms of it is 39% is cutoff value. So these are the general cutoff values below which you can call anemia. And all of you know that if it is less than 7 grams, it is severe anemia for anybody. Okay. So that mild, moderate, severe I am not giving here. The treatment aspect, it's important. Now, how prevalent it is. The prevalence of anemia in preschool children, in developing nations it is 42% and developing nations 17%. Whereas in school children it is much more common, nearly 53%, and in developing nation naturally less. In pregnant women even more common, 56%. Men generally it's less, 33%. And latest is actually, all of you are familiar with the national NFHS report, the National Family Health Survey 5. This report is 2020, has come recently. There are 22 states. So fortunately Andhra Pradesh is there in one, because another 7 states there still surveys is going on. Actually the compiling is going on. So as per the NFHS 5 report, this is the latest one, the prevalence of anemia between 6 months to 5 years is 63%, 10% increase in the previous study. So that is the latest information I have got for you. So please remember that prevalence is 63% in under 5. So this is a MCV based. There is a hemoglobin, the indices, RBC indices are there, no? Based on that, how do you classify this anemia? You do that MCV, all of you know the mean corpuscular volume. If it is above 797, that's very good. Actually, it is supposed to be between 80 and 95. If it is above 97, it goes into macrocytic, big, all these megaloblastic anemias and all this. 80 to 97 is almost normal sizes, but if there is already anemia is there, it is a normocytic anemia. If the MCV is less than 80, it becomes under microcytic anemia. This is a femtoliters actually, all of you know.
Sorry, this is class of.
Hello? Emma? So this is a bedside formula to determine lower limit of a normal MCV. What is normal MCV? Because again, I said in children, nothing is a fixed value. So the formula is 70 plus age in years. That's all. Suppose the child is 5 years. 5 years child, the MCV below 75 it is called as a microcytic. If it is 10 years, 70 plus 10, anything below 80 is MCV. If it is 15 years, anything below 85 is a microcytic anemia. That is a general rule of thumb. Usually, by definition, anything below 80 is a 80 femtoliters. It is called. The units are femtoliters. Please remember that. Now coming back to the nutritional anemia. So what could be the causes of nutritional anemia? All of you are familiar. The first and foremost is iron. Iron deficiency anemia is the most prominent because we spend more of today's talk on the iron deficiency anemia. Okay. Then the vitamin B12, the folic acid deficiency, and minor deficiency like riboflavin, pyridoxine, vitamin C, vitamin A, in trace element deficiency, copper deficiency, like that actually, and protein deficiencies. So all these things are related together. It is called as a causes of nutritional anemia. We spend more of today's on the iron deficiency anemia. So iron deficiency anemia, the most prevalent. Nearly 72% of children up to 3 years in urban and 82% in rural areas worldwide. The areas of anemia. Children and pregnant women very susceptible. Not only the anemia, it affects the oxygen carrying capacity, as these children are pain, it affects the development also, and the work performance, resistance to infections, all these things are affected, not just oxygen carrying capacity. What is normal requirement? Why is deficiency? Because is the child taking normal amount of iron or not? So these are the recommended dietary allowances, RDAs it should be. Recommended dietary allowances for infants it is 6 grams per day. Children it is 10 grams. Adult male 12, adult female 11 to 14, especially the old, the lactating and adult, because they keep losing to the periods and all. Pregnant female, because for the baby also, it's 15 grams is the minimum iron requirement in grams. So remember 6 and 10 for pediatric age groups, normal daily requirement of iron. So in the Viva also this comes again, questions keep coming. Just remember them. What determines iron absorption? So these are some of the factors. Even if you are taking iron, there are factors which influence whether it goes inside or not. Generally, this type of source, the heme iron has got a very bioavailability is very high. There is 20 to 30% is absorbed. Whereas non-heme irons availability is only 2 to 5% only. So that depends upon the what type of iron you are taking. There are certain promoters which increase the absorption. They increase even up to 40% increment than normal. Example, acidic medium, there is ascorbic acid, vitamin C. That's why I always take iron with vitamin C when you are taking supplementation. Germination, the seeds are usually, the pulses, germinating pulse. That's why we ask you to take the germinating pulses like sprouts. They increase the absorption capacity. And also fermented foods. Fermentation process also increases the iron absorption from the content of the foods. Whereas there are inhibitors of the iron absorption, specifically the phytates. They are present in cereal. Most of the cereals they have phytates. And tannin. See, in the tea and coffee, they got a tannin. Calcium and soya proteins. These are generally, if you're taking along with the coffee some iron tablet, the absorption is very, very limited. So these are the implications when you are taking supplements. Please do not take with coffee and tea. Avoid this with a heavy cereal food, following cereal food. If you take iron syrup or tonic, the absorption is inhibited like it. So these are the precautions you have to advise parents when you are prescribing iron preparations. Why are children and especially infants more prone? Because the maternal iron deficiency. Because the mothers who are deficient in iron, the deficiency continues into the infancy also, because these children are born with a limited the storage capacity of the iron. The iron stores are very, very depleted. So they are prone for, if the nutrition in a few days of iron supplementation is not there, they get into frank anemia. All of you know breastfeeding, breast milk is very good, but still the iron content of breast is very, very limited. Breast milk. It is okay until 6 months, but beyond 6 months for the growing child, if your child keep on getting only breast milk, that child is prone for anemia. So that is the purpose of using weaning foods. Complementary foods purpose is to supply the minerals which are not there in the breastfeeding, which are necessary for the growing child. Most important is iron. So iron supplementation essential beyond 6 months. Even if they are weaning has started, that complementary foods that you are giving, they're not good initially, because mothers do not know making the cereal, as I said, cereals are because of the phytate content, the absorption from the cereals is not so good. So only pure cereals are being fed to babies. They get into it. The complementary food quality is also important. So that is the reason most of them, the infancy, they are prone for anemia. What happens if the iron is deficient? See, it is mainly the impairment of the mental and motor development, poor concentration, children can inattention, distractibility. These children, especially growing age, the growing neurological tissue requires iron for its proper functioning. Their physical performance, the limits have diminished because the oxygen carrying capacity reduced, the endurance has decreased. That's why he doesn't want to play. The motor skills and so the productivity. Child cannot do his normal activities. That's why he always goes and sits someplace. He cannot take part in good strenuous exercises, sports, and all this. The decrease in physical activity affects their learning due to limited exploratory activities. You cannot go for a trekking, you cannot go for a swimming like that. Actually, all these things, child became restricted. So the cumulative effect is the school performance. Results in it. Sometimes they may even drop out. They cannot go to school also. So these are all the adverse effects in a growing child, especially the lack of iron affects so many ways, socially, physically, health-wise. So this is just nutshell diagrammatic representation. It is absorbed iron. The site of maximum absorption is there, duodenum, and it gets deposited and goes to the bone marrow. Ferrous form is ideal, is better absorbed to the muscle, heart, pancreas, bone, and circulating system. Always it is distributed in the liver. Is the storage in the hepatocytes. Excess iron is there. It is stored in the. And in erythrocytosis, erythropoiesis in the RBC, 65% of the total binding iron is in the form of a hemoglobin. So the remaining 35% is distributed in the other areas, as you can see. This is from the Nathan and Ask hematology. Myoglobin, enzymes, and storage vary at 30 milligrams per kg. The iron is in the form of a muscle and various iron-containing enzymes and storage from the bone marrow, etc. So most of it is in the form of hemoglobin for oxygen carrying capacity. So anemia, iron deficiency anemia, why IDA has come? As I said, the inadequate intake, so maybe nutritionally not sufficient either because of the lack of food or because of the lack of knowledge, the caretaker. So whatever it is, the intake has diminished. The other possibility is intake is okay, but it's not bioavailable. As I said, it's being not being allowed to absorb, not being willing to assimilate it. So the bioavailability of the iron that you are taking is very, very little. That's why even if you are taking, it's not getting into the body. There is absorption is prevented by some reason. The increased need of iron because the child is growing faster. Actually, RBC is forming more, especially the hemolytic conditions actually associated with iron also deficiency. For the increased demand, the existing intake is not sufficient. That is increased demands, high metabolic rates, such things. There is a chronic blood loss due to worm infestation. Actually, it is not considered as a nutritional anemia, but just to say iron deficiency anemia can happen because of that also. And the non-specific causes chronic infections also produces iron deficiency anemia. These are last two are non-nutritional anemias. So you need not mention when you're talking about specifically about nutritional anemias. And this is only in iron deficiency anemia means you have to write all these things. So when your question is nutritional anemia, you need not mention that. You have to differentiate the question what you are asked. Actually. Now, in a case of iron deficiency anemia, how do you approach it? The history tells you many times. Actually, what are the symptomatology? It tells you. Is your child having pica, eating mud, and all those things? Interest in non-edible substances is called as a pica. Is he having any breath holding spells? One of the most common reasons, the treatable cause of breath holding spell, apart from the behavioral problems, is the iron deficiency anemia. Is he getting tired easily instead of go on playing just 5 minutes and comes back and takes rest? So this type of history, if the mother is giving, you must suspect iron deficiency anemia. And if the nutritional history, you can ask the mother what type of food he will be feeding. Actually, how long child has been on the breastfeeding, exclusive breastfeeding. After breastfeeding, the weaning, when was it started and how it started, with what foods it started. Actually, all these things will tell you the possibility of a nutritional anemia. In the physical examination, there are telltale signs. We'll come to that later on. So, and then we do some laboratory investigations to confirm your diagnosis. Then we talk the management. So any approaches, any disease, actually, these are the general factors. How it started. You take the proper history, do a physical examination, do some confirmatory tests, and then plan management. These are the steps common for any type of approach. When you're asked to approach to any disease, remember these steps and you display them, write them very clearly in the beginning itself. These are the things I'm going to discuss. Instead of starting writing in paragraphs and paragraphs, first tell the examiner what you are going to write. So even the seminars also I tell them what we are going to, the contents. At the end of the session, what is listeners will know about it. So until you become experts, have the contents page always. The exams also, when the question is asked, so these are the things, headings I am going to write my answer. You first write that. That itself gives the impression to the evaluator. Then under each heading, actually you can check it also. Did I cover this? Did I cover this? Did I cover this? Otherwise, keep on writing. After some time, you don't know where to stop, Actually, if something way better, you keep on writing, and then you forget in the later points in management. That's it. Coming to the clinical features in the examination, as I said, the symptomatology are of easy fatigability, irritability, shortness of breath, lassity, lack of interest in surroundings like this. Poor school performance. If it is school going child, you can ask. Pica, already I told you, interest in non-edible substances. If it is a rice, it is called as a myelophagia. If it is a mud, it is called as a, what is called? There is, for each type of food, there is a name. Geophagia. So amylophagia, pagophagia, that means eating food, tree products like that. Breath holding spell, especially the palate type of breath holding. You know, the breath holding spells, you know, of the cyanotic type and palate type, anemic type. Usually the palate type is supposed to be associated with the anemia. Worm infestations history. Because the pica, they keep on eating and all those things, the chances of getting repeatedly worm infestations. And also I didn't mention here, actually the proneness for stroke, pediatric stroke, and somehow the anemia increases the chances of a pediatric stroke. So these are the clinical manifestations, how they come, and when you examine them, so this is a physical signs, the puffiness of face, pallor, edema of feet, hemic murmur. Actually, edema and all these things, when they present the severe anemias with cardiac failure also. The pale and bald tongue, angular stomatitis, though it is called the riboflavin deficiency, but still in anemia also it can happen. The flat and cupped nails, you know the names for them actually. Okay, platinicia, chylonychia. Hyperpigmented knuckles, these are not with iron deficiency anemia, with the other type of anemia actually, the megaloblast. What is called the Plummer-Vinson syndrome or Patterson-Kelly syndrome is a triad of dysphagia, chylonychia, and splenomegaly. This is a rare phenomenon, but some examiners are fond of it. As I said, stroke proneness. The laboratory investigations, in this heading, the most important is the hemoglobin estimation. Cyanomethemoglobin method is usually common what we are following the laboratory. If you go to clinical pathology, I think this is the one they might have told you, taught you, cyanomethemoglobin anemia. Now, HemoQ-HB photometer, actually, this is a, it looks like your pulse oximeter, I think, which is the point of care determination, especially the Anemia Mukt Bharat program, actually, under the government of India is now promoting this, where you are supposed to diagnose anemia at the field level. So you cannot keep carrying all the reagents and all these things. That's why one of the point of care instrument is a hemoglobinometer. They have developed now. It looks like your glucometer, something like that. Just a drop of blood is just put it on that. It will tell you the hemoglobin levels. So these are the two methods. One is a laboratory one is a field one. Then peripheral smear, it tells you many things about the RBC structure, whether it is hypochromic or microcytic, and various, there are so many indices are there. So some of these indices to remember is, as I said to you, my mean corpuscular volume, anything less than 80 femtoliters is a diagnostic of a iron deficiency. There is microcytic hypochromic. Whether it is iron deficiency or not, you have to pinch upon the, the differential diagnosis of microcytic anemia. Thalassemia, you have to rule out all these things. MCH, mean capsular hemoglobin, less than 27 picograms. PG means picogram. And MCHC, almost like a HCT actually. It is a below 33% is a mean corpuscular hemoglobin concentration. And RDW, all of you are familiar with what is RDW? Red cell distribution width. So that is more than 14.5%, because RD red cell distribution width is an indirect manifestation of the anisocytosis. In iron deficiency anemia, there are microcytes, and also there is various different sizes, and are not constantly one same size. That is typical of iron deficiency anemia. That's why the distribution width ranges is very high, that is about the 14.5. Whereas in thalassemia, they're almost at the same size of microcyte, because the RDW, the range of change in the size of the anisocytosis is less there. So that is why thalassemia, there is especially intermediate thalassemia, there is main differentiation. Clinically, they don't have all the thalassaemic phases and all those things. So the differentiation mostly depends upon the laboratory parameters. At such cases, RDW less than 14.5, more likely intermediate thalassemia. RDW more than 4.5, In a microcytic anemia, it is more probably it is a iron deficiency anemia. Hematocrit less than 33%, already I told you. And the other laboratory investigation, this is second level manifestation. These are the routinely we don't do that, but when you confirmation, especially management size sometimes we do this. The serum ferritin levels less than 12 nanograms per ml is a diagnostic of IDM. Serum iron usually is not so diagnostic because iron deficient serum iron levels may vary in inflammation also, it may come down actually. But the cutoff level for serum iron is anything less than 35 micrograms per deciliter is a iron deficiency anemia. But TIBC is a more diagnostic, that is total iron binding capacity more than 470 micrograms per deciliter is a typical diagnostic of it. That means iron binding capacity has increased. It means actually it's not been full. So increase in TIBC is diagnostic of iron deficiency. Now more reliable parameters are transferrin saturation. Transferrin is the one which transports the iron, free iron. In infants, transferrin saturation is less than 12% is iron deficiency anemia. Children, less than 14% is a iron deficiency anemia. And serum transferrin receptor more than 9 milligrams. Actually, usually we ask the postgraduates, undergraduates. The most important finding in the bone marrow is reduction of the stable iron and erythropoiesis also decrease. These are the bone marrow features of a iron deficiency anemia. So secondary investigations, these are. Coming to the signs and symptomatology, as I said, the irritability. Look at the child. Always, like once in a way, every child cries, but the child keeps on always like dull looking, crying. That is, you must suspect something wrong with the child. Pallor. You can see looking at that is diagnosis. It's actually Sparta. Baby is fair. You can think it is a fair, but actually you can easily make out the skin fairness or really lack of iron deficiency anemia. At different age groups, bigger children, pallor. You can look at the tongue, very pale. And the common sites, you look at the palpebral conjunctiva. Remember the examination they ask the palpebral conjunctiva and the palmar creases and tongue. These are the conjunctiva, tongue, and palmar creases. Three places. These examiners are very fond of asking you, where do you look for anemia? Don't say eyes, don't say mouth, don't say hand. You have to be very specific. It is the palpebral conjunctiva, and it is the tongue and palmar creases. Please remember. Lethargy, not interested in games at all. And the tachypnea, because of the anemia, they may go to because oxygen carrying capacity decreases, always now oxygen hunger. Tachypnea is a typical of anemia, especially. Angular choroiditis or cheilitis is called as suggestive of iron deficiency anemia. This is atrophic glossitis. Also looks like a sometimes geographic tongue also looks alike because geographic tongue is a benign thing, whereas atrophic glossitis is because of a anemia. They resemble a little differential diagnosis. This is what is called as a flatinic. When the nails become flat, it is called as a platanichia, and when they become concave, it is called as a koilonychia. This is usually seen in the severe anemias, not so common in children. We may see platanichia, koilonychia as well seen in only severe anemias. Now peripheral smear, you can see on your left what is a normal blood smear. See, okay? Usually the pallor is confined to the central to 1/3. Whereas the anemic patients, you see, it's almost like pale thing, only a small rim of darkness around surroundings because of the thick area that is. So that is how the peripheral smear look like a normal blood smear and a patient with anemia. And also you can see the various different sizes, also different sizes. Here almost they're on your left, they are almost similar size. On your right side, some are very small, some are little tinier, different anisocitosis, and poikilocytosis is different shapes also. Anisocitosis deals with the size, Poikilocytosis deals with the shapes also, distorted shapes and all these things. Actually typical of a patient with iron deficiency anemia. How do you manage them? So if the hemoglobin is less than 5 grams, there is chances of cardiac failure are very high. It's an emergency situation. You require hospitalization, preferably give a blood transfusion. And you cannot give whole blood also because they are also prone for cardiac failure. Already blood volume has increased. So always give a packed RBC, preferably a washed packed RBC, 2 to 3 ml per kg at one time. Then you can supplement with the iron deficient. Once these beyond that 6 grams or something like that, you can think of giving oral supplementation. Oral therapy, the dose is 3 milligram per kg per day. This is a very, very common question, either in the exams and the viva, practicals and clinics, whatever it is, everywhere. What is the dose of iron? You must be at least maybe knowing the iron deficiency management is 3 milligram per kg per day orally in the form of a ferrous sulfate, gluconate or fumarate. You know the ferrous sulfate, each one percentage of absorptions of the ask. I'm not covering here in a minute. Preferably on empty stomach because better absorption, and minimum of 3 months after hemoglobin become normal. Why? Because it has to replace the stored forms also. Whereas glycine sulfate, carbonyl iron are also all these things, hemoglobin iron, all these things are there. They're costly and their bioavailability is not so consistent. That's why still ferrous sulfate is considered the best method. Now, in addition to the treatment, you give some advice, dietary advices also. Decrease milk intake. So milk, because of its alkaline pH, it inhibits the absorption of the iron and reduce it to the nearly 16 or 24 ounces a day. Promote iron-rich foods like vitamin C, oranges, like C vitamin, which contains fruits, which contains acidic products. Multivitamin with iron is not adequate. Please remember that I am already giving MBA with iron and it's not sufficient. When you are treating iron, you have to supplement properly iron preparation. So advise them to take with juice because juice contains citric acid. Meat to enhance the absorption. Definitely not milk. Please remember that. Intravenous iron for malabsorption cases suspected because there is only in cases where you suspect there is a parental iron form is also there. We don't use much in pediatrics because iron sucrose formulations, especially in the guy OBG people, they will give. In pediatrics, we rarely use it actually. Only in case of a malabsorption cases. What are the common adverse effects of iron? Commonest is a constipation and a metallic taste in the mouth and teeth staining, especially the high concentrated iron preparation, thick forms actually stain iron. It is a transient one. Very rarely anaphylaxis and hypotension. These are the common adverse effects of iron preparations. So how do you know your iron is working or not? Actually, that is depend upon this one. Within 12 to 24 hours, what happens once you give iron, the enzymatic iron, it gets replaced. So there is a subjective improvement will be there. The irritability and that lack of interest, those things they will improve, and appetite will improve. These are the immediate differences you see, especially severe anemic patients who are supplemented with iron. After 1 to 2 days, the erythroid hyperplasia starts. If you check the bone marrow, usually we don't do that. And 2 to 3 days, that is 48 to 72 hours, then the reticulocyte count increases. So retic count, that is only physical. Clinically, laboratory wise, you can observe the change in the retic count after 3 days of the hemoglobin. Hemoglobin should increase at 1 gram per deciliter per week. So if the child is on a 7 grams, after 1 week, when you check the hemoglobin, it should be 8 grams. That means they're reasonably good. So you cannot just changes of hemoglobin. So that is a normal clinical parameter. If you are doubtful about that, actually it's not happening. So this is the 1 gram per deciliter per week, most important. After 1 to 3 months, that's why we ask you to continue 3 months after the hemoglobin become normal. That is for necessary for the depletion of the hepatic stores. So this is the reason for continuing long run. Suppose these things are not happening. So this 1 gram is not increasing. In spite of giving months together, it's not happening. So then you suspect what are the causes for this. First and foremost, non-compliance, because my baby didn't like sir. Actually, every time she's vomiting, sir. So non-compliance is non-compliance, non-compliance. The first commonest problem. So why I repeatedly put it is check the bottle in the clinic. Many times parents are so lazy. First of all, before you jump to the next level of management, rule out it is not a non-compliance. Then look for the underlying causes, because you are giving. There is, if it is a adolescent girl, it is most probably anorexia or something. Baby child is losing in spite of your treatment. She is losing for some other reason with excessive bleeding. Or cow's milk energy, because in all of you know cow's milk protein energy, silently they're losing blood with a microscopic blood losses to the stool. So it's not even evident. So you have to rule out this CMPA. Another cause of malabsorption like celiac disease, inflammatory bowel disease, and various genetic mutations are causing Crohn's and such things. If we rule out all these things, then again come back to your diagnosis. Are you diagnosed with iron deficiency correct or not? Are you missing any thalassemia? Are a thalassemia intermediate or a milder forms of these things, abnormal hemoglobins? So that may be the cause for the microcytic hyperkalemia. So this is how you approach dealing in iron deficiency. All of the rich iron-rich foods, the pulses, green leafy vegetables, broccoli, liver, mushrooms, and red meats, various raisins. This is actually kismis, such things, and pista, various pulses, eggs, some of the common sources for the iron. Now we come to the other type of nutritional anemia, the megaloblastic anemia. So what is a megaloblastic anemia? Is a group of disorders characterized by presence of a distinct morphological features of the developing red cells in the bone marrow. The bone marrow is hypercellular and anemia is not due to the dyserythropoiesis. What happens here, the DNA formation is affected. That's why RBC not able to develop properly. So these are the typical megaloblasts are type of macrocytes with distinctive features. We'll come to that what they are. The common causes of anemia, megaloblastic anemia are vitamin B12, folate deficiency, thiamine deficiency, and drug-induced various like especially antimetabolites like methotrexate induced. Again, this is also through folate causing the loss of folate actually. So most important of these two, we are going to discuss only B12 and folate today. Now, megaloblastic anemia. So how do you know the mean corpuscular volume has increased? So between the ages 2 to 10 years, age into 0.6. This is the formula plus 84. So if it's 10 years, 10 into 0.6 is 6. So 84 plus 6 is 90. Above 90 femtoliters is called as megaloblastic. If it is a 5-year-old child, only 5 into 0.6 is 3. So 84 plus 3, 87. Anything above 87 is megaloblastic. So there is a rough indicators of this. MCH may be normal or increased. Because the size of the RBC has increased doesn't mean the hemoglobin content has increased. Sometimes it may be normal, sometimes it's even decreased. Same with the MCHC. Usually they are associated with leukopenia and thrombocytopenia also, because it is after all necessary for formation of nuclei of these cells also. In 30 to 70%, it is a pancytopenia. All three lines, RBC, WBC, and platelets, all are decreased. So whenever you come across a case of pancytopenia, think in addition to the aplastic anemias and leukemias, megaloblastic anemia is a differential diagnosis for them. The folic acid, we will talk about the folic acid, is necessary for the DNA synthesis. It is commonly sold. The food sources are liver, soybean, dark green leafy vegetables, etc. The normal serum concentration is 2 to 20 nanograms, and commonly we come across the deficiency in pregnancy, malabsorption conditions, tapeworm infestation, especially fish tapeworm. Excessive cooking destroys folic acid. Some drugs like phenytoin, antimetabolites, they interfere with the formation of the folic acid. Chronic liver disease and alcoholism are the known causes of folic acid deficiency. Folates aid in production of the RBC. Folate aids in synthesis of DNA. Folate works with B12 and vitamin C to help the body digest and utilize various protein digestions. So these are the purposes of a folic acid. And you see folic acid also called as a vitamin B9, not so commonly used. Commonest sources, food sources are again green leafy vegetables and cereals, whole grains, dark green leafy vegetables, poultry, pork, shellfish, and liver. So these are the common food resources. Coming to the B12, again, this is also necessary for DNA synthesis. The source is mainly animal origin because it's not seen in the vegetable origin, eggs and meats and fish. So, who are prone for this B12 deficiency? The pure vegans who don't take even milk also. Such people are actually susceptible for B12 deficiency. Delayed weaning, again, exclusive breastfed babies, they develop. Pernicious anemia alone, there is a different absorption deficiencies. It is B12 is there in the food, but actually it's not been getting into the intrinsic factor deficiencies. Pernicious anemia, rare condition in children. There, the post-surgical, if the ileum is resected or intestinal small bowel developed also, I think because of the area of absorption is diminished. That's why you don't do the tropical flu and Crohn's disease, inflammatory bowel diseases, also the disease, B12 deficiency causes rarely. And recommended dietary allowance per day is 1 microgram per day. You know, the B12 is necessary for the brain development, spinal cord, and red blood cells. It's an important part of metabolism. So the central nervous system requires B12 more, and the brain and spinal cord. That's why B12 deficiency manifests with the neurological manifestations. As again, the sources, as I said, the eggs, meat, poultry, shellfish, milk, and milk products. What are the clinical features? Megaloblastic anemia, the pallor is common in me. Glossitis and angular stomatitis, irritability, just like iron deficiency anemia, severe anorexia and failure to thrive. Knuckle pigmentation is a characteristic of megaloblastic anemias. The tremor and developmental regression, especially B12 deficiency. There may be jaundice, signs of extramedullary hemoptysis. In B12 especially, the CNS manifestations are very common, like peripheral neuropathy, paresthesias, subacute combined degeneration of the spinal cord, lethargy, hypotonia, seizures, psychiatric disturbances are common with the B12 deficiency. This is the peripheral smear. You can see how it looks. These are the megaloblasts because macroovalocytes size is increased size compared to normal RBC. This is a characteristic finding: hypersegmented neutrophils. Neutrophils actually more than 5 segments. So these are all segments actually should be usually normally less than 4 or so. So hypersegmented neutrophils are diagnostic. This is another one, teardrop cells common in the megaloblastic anemia characteristic. If you are asked examination, try to draw simple diagrams. You can just easily show. Instead of writing a paragraph on that, just one neutrophil you show with multiple new globules, and you could see normal RBC and show some larger RBC. You tell them this is a megaloblast. And abnormal cells like teardrop cells you can put. It is as simple as this. That will fetch you good marks. How do you manage them? The management and administration of the B12 deficiency, you would bring B12. If it is a folic acid deficiency, you give folic acid. Doses of B12 is 100 to 200 micrograms intramuscularly biweekly or 1000 micrograms weekly for 4 to 8 weeks. This followed by daily 100 micrograms per oral day. This is the dosage for B12 deficiency. If it is a folic acid deficiency, dosage is 2 to 5 milligrams per day orally and 5 milligram per week for 4 to 8 weeks. This again replacement of this dose. How do you know replacement? Bone marrow gets reverted totally within 24 hours is the megaloblastic anemias. Patient starts feeling better. Retic response takes 1 week for them here to develop. Hemoglobin starts rising after 1 to 2 weeks and normalization in 3 months. And peripheral smear becomes normal after 1 to 2 months as old macrocytic RBC will persist till that time. So that is a minimum time of 2 months, 60 days. So this is how you monitor whether your treatment is working or not. There are diagnostic tests actually these should have come before. Macroovalocytes in RBC, multilobular or more than 5 lobules nuclei and neutrophils. High RDW, because here also poikilocytosis is there. Polychromasia, that is different coloring actually, grayish color and actually the different fades of hemoglobin shades. Basophilic stippling and Howell jelly bodies in the inside RBC are common in the megaloblastic anemias. Bone marrow shows megaloblasts. And serologically, serum B12 less than 150 picograms, serum folic acid, if it is a folic acid deficiency, less than 3 nanograms. Erythrocyte folate levels are more diagnostic, it is less than 150 is correct diagnostic. And most of the therapeutic trial, if you give a treatment, I can see after 1 to 2 weeks, and the retic count increasing, that shows a therapeutic trial. The diagnostic method. How to prevent it? These are the national programs. 12 by 12 initiative started in 2017. Every child would get hemoglobin of 12 grams by age of 12 years by 2012. That was the time when they initiated this one. And of course, we are past 2012 by now. Actually, now the National Nutrition Anemia Control Program, NNACP, is there. Weekly Iron Folic Acid Supplementation Program is there. WIFS, National Iron Plus Initiative, NIPI, etc. to combat anemia. By 2013, the aim at providing comprehensive package of continuum of care along the treatment and management of anemia. And Anemia Mukt Bharat initiative started in the 2018 and under the Poshak Abhiyan curriculum. Actually, a Pradhana Mantri or outreach. Poshak means a Pradhana Mantri outreach for the implementation of various products under one umbrella. So Anemia Mukt Bharat comes under. If you write this in any question on iron deficiency anemia or nutrition anemia, you just mention this Anemia Mukt Bharat. This is the symbol of the Anemia Mukt Bharat. If you can draw the drop of blood, you can be even better. So this is designed to reduce the prevalence of anemia by 3 percentage points per year among the children and adolescent and women by reproductive area based on the 2018. So what was there between 2018 and 2022 per year, they have to bring it every year 3% less the prevalence. So that is the aim, and approximately 450 million beneficiaries are covered under this, nearly 50% of the country's population. So this is a very, very, very bold initiative, and it has got the most important thing is just mention this 6 into 6 into 6 strategy. So what this is, there are 6 beneficiaries, 6 interventions, and 6 institutional mechanisms. So these undergraduates may not be that necessary, but actually we'll talk about 6 interventions only. So what are the 6? Prophylactic iron folic acid supplementation. So for all these people who are susceptible, is the first step is prophylactic, this one. Deworming, regular deworming. Intensified behavior change communication, that is actually solid body, smart mind, including ensuring delayed cord clamping. So as soon as the various behavioral aspects of the child care. So delayed cord clamping and actually nutritional aspects are all these covered under these behavioral changes. Now testing the anemia digital method, this is what is called as a point of care testing actually. This is a POC. Taking hemoglobinometers to the field and test then and there itself and tell whether the patient is anemic or not. Number 4. The 5th is mandatory provision of iron folic acid fortified foods. The food fortification is very, very important. The iron folic acid especially, various foods are fortified. And the last one is addressing non-nutritional cause of anemia, like endemic pockets, special focus on malaria, hemoglobinopathies, and fluorosis. If they control automatically, indirectly, the anemia, nutritional anemia is also covered. So these are the 6 factors in the interventions. And don't bother about the beneficiaries. Actually, all the various age group, they are divided into below 6 months to 5 years children, 5 years to school going children. Second, third is an adolescent, and fourth is the pregnant mother, fifth is the lactating mothers, and sixth is actually age group women who are not pregnant or not lactating but still in that age group. Like that, actually all 6 groups are there divided into people. These are all covered. And 6 institution mechanisms are actually various levels: district level, state level, national level, and central port. There is a website, and all these things are covered on the institutional mechanisms. So 6 into 6 into 6 strategy, you write that, and you write, remember this Anemia Mukt Bharat under Poshak Abhiyan program. So that covers the iron deficiency anemia. Thank you very much. Thank you all guys. Okay. Best of luck.